now?
Yeah, okay.
Okay, great. You have 2 minutes to read the scenario and to put your plan, because you know in station 5 it's 2 patients, so you should read everyone in 2.5 minutes. So you have 2 minutes from now just to read, and let's go through the case.
لا
Dr. Muhammad Ali, Dr. Muhammad Ali, can you please close your mic because I can't close it from here? I need you doctors to put your plan as well. All the doctors try to put your plan in order to see what the right and wrong things you're doing. So 2 minutes done, doctor. Let's start, please.
Yeah. Yes, okay.
Again, this station 5, don't forget the examination, okay?
Yeah. Hello, sir. I am Dr. Ragib Nisiri, one of the doctors in the medical duty today. Nice to meet you. I understand from your GB letter that you have dropping of your eyelid. Can you tell me more, please, about that?
Yes, doctor. I had a surgery for which I was admitted since 10 days, and I had a surgery that was done at that time, and I had some problems after the operation. Okay, then I found that recently the physiotherapist told me that I have a problem in my eyelid, and when I looked for that, I found, yes, it's there. There is a problem, there's dropping in my eyelid.
So I understand. Can you describe symptoms before the operation, please? What you are suffering from?
There's a problem in your connection, Dr. If you're asking about if this problem was present before my operation, so no, this is new.
Yeah.
Yes.
So, yes. So, did you suffer any headache before?
Headache? No, actually, sometimes like normal headache, but I'm not a headache man, by the way. Yes, doctor.
Yes, Dr. Ten?
Yes.
Yes.
Yeah, no headache.
Yeah. So, any blurring of vision?
Blurring of vision? No, no. So far for now, no blurring of vision. But the problem, I really feel that this eye dropping, I'm worried that it will affect my vision later on.
Yeah, I understand. Do you have any problem in your vision? Any problem in peripheral or central vision?
No, none.
Yeah. Any sensation of double vision?
Double
Any
vision?
feeling of
No,
double
no,
vision?
no. Just I think I'm a little bit tired, so maybe this is the cause of my eyelid problem, doctor. I'm not sure. I don't know.
Yeah, well, I understand. So, any muscle weakness? Any muscle weakness?
Weakness? No, no, I don't have weakness, doctor.
Yeah. So, any change in the sensation in your face at all?
No, no.
Yeah. Well, so, so okay. Any red eye?
Red eye? No, no.
Yeah. Any eye pain at all?
Eye pain? No.
Yeah. Well, yeah. So, you mentioned that. So, um, any other troubles or any other symptoms
Any
before
other
your result?
symptoms? No, just this eye drop. Other than I have, after my operation, I had some chest infection, and I was treated for that. So
Yeah.
I think I'm fine now. The only thing that this physiotherapist told me, and I really noticed that my right eye lid dropped down.
Yeah. Well, I see. So, did you smoke at all?
Yes, I'm smoking 5 cigarettes a day in the last 20 years. 5 minutes now, though.
Yeah. Yeah.
Would you
Well,
examine me, doctor?
so did you drink alcohol at all?
Yes, I'm drinking two cups
Did you
every
drink?
day. Only in the weekend.
Examination.
Yeah. So yeah, yeah. May I have a look, please? So I would
Sure,
like
doctor.
to examine eye movement.
Yes, eye movement is normal, doctor.
Yeah, I want to examine to the visual field.
Visual field is okay, doctor.
Yeah, I would like to examine the pupil size
It is
of the
small,
pupil.
doctor.
Yeah, small. Yeah, so I understand. Yeah, so have you noticed any change in the sweating in your face? Sweating, any change in sweating in your
Yeah,
face?
it's like there is some redness in half of my, my shoulder and my face. It's more red, and I think, yeah, the sweating is not normal. It's very weird, doctor. It looks like half of my body
Yeah,
only respond to this heat. I'm not sure what it is.
yeah. Well, so I would like to examine
Two
the
minutes
neck of
remaining,
each
doctor.
part. Yeah, yeah. So would you like to? Do you have any concern?
Yes, doctor. I want to know what happened to me. What the problem? Okay, and is it persistent, or
Yeah,
it's temporary and it will relieve, it will be solved? Okay, and I also worried about, is it stroke? I'm worried about stroke. My father have a stroke.
yeah. I understand your concern. Yeah. So before replying your concern, I would like to ask you if there is any operation in your neck, any operation in your neck at all?
Operation in my neck? No, I have this
Yeah,
operation done to my. I have operation done to my chest.
yeah,
Okay.
yeah. I understand. Yeah, yeah. So you have a condition called the Horner syndrome.
Okay.
Uh, yeah, this condition uh, happen when the nerve supply of your eyes or nerve supply of your eyes are damaged by the during the operation. During the operation.
Oh, so they destroyed my nerves, doctor.
Most probably it is damage to the nerve supply, to the nerve cable which is supplying your eyes. So what we are doing to do today, we will refer you to the eye doctor. Also, we will carry out some investigation. We will carry out some investigation to your condition. I can't determine if this condition is reversible or irreversible. It will depend on the extent of damage happened to the nerve cable of your.
Okay, time finished, doctor. Thank you. Time finished,
Yeah,
doctor. Thank you. Okay, now 2 minutes with the examiner. So, doctor, what is your diagnosis for this patient?
Yeah, my diagnosis for this patient is a Horner syndrome. There is ptosis, there is meiosis, there is anhydrosis in one side of the face.
Yeah, what do you think the cause of this?
Yeah, I think the cause may be damage to the sympathetic ganglion during the operation.
Yeah. So, can that explain the anhydrosis? If the sympathetic chain is destroyed due to the operation, can that explain the anhydrosis with the patient?
Yeah, I think the anhydrosis may relate to the damage to the sympathetic ganglion or somewhat like that.
You mean this is a preganglionic or postganglionic, in your opinion?
Unfortunately,
Okay,
I don't
thank you, doctor.
remind now the difference.
Okay, what will you request for this patient?
Yeah, for this request, we will request basic blood investigation like CBC, liver function test, kidney function test. We also will request CT chest.
Yeah.
CT chest.
Yeah.
Okay.
Yes. Okay. So, do you think this patient could have you care about if you have cancer? Is there a possibility of cancer? Did you ask about any risk of cancer?
Sorry, any risk factor for what?
Cancer.
For cancer?
Cancer. Yeah.
Yeah. Uh, uh, um,
Okay.
like to
Time finished, doctor. Thank you very much. Thank you. Okay. So thank you, Dr. Masiri. You did the case well. Here, I want to start by just a trick, which I just add to the scenario. I just tried to add because I feel Dr. Masiri is a little bit late in reaching the diagnosis because he asked it on the pupil rate, so late. So I just add to him the point of anhydrosis to make it more easy. But actually, in this scenario, this history, this is a case of postganglionic. Okay, for the postganglionic Horner syndrome. Okay, and I will discuss in brief what is this, the pre and the postganglionic causes. But in the postganglionic, it's not common to see anhydrosis. The anhydrosis will be for higher level of the hormones. Okay, so anyway, if you found the meiosis and if you found the ptosis, you should put in your consideration the differential diagnosis I'm going to discuss in the next minutes. Okay, but anyway, again, doctor, you did the case well, but again, I want to remind all of you, our aim of our lecture is to have an approach for everything. I don't want you just to try to hit here and there, because this is good, you catch it today, but what if you found in the exam any new case that you never hear about before? Okay, I want you to have approaches for the things. So I need you in your mind, if you found any ptosis, to memorize my page or our page. So just memorize it, just try to exclude the differentials and to reach the definite diagnosis that you are requested to reach, then you will get the full mark. Okay, so again, you did very well, but I want you to be very organized in excluding the things. Okay, I want all of you, please, in the chat box to give me what the differential diagnosis you know about the ptosis. Okay, I'm not talking about this scenario, I'm talking in general. Just give me word, everyone give me one diagnosis about one differential of the ptosis, you know. Okay, so myasthenia, Horner, myasthenia. Okay, what else? Congenital. Okay, third nerve, myasthenia. Third Horner. Okay, myotonic there. So you all say three things. What else? What else? Pancreas tumor, so it will cause Horner, you mean? Okay. So here we go. Yeah, here we go. Heterogenic. So thank you. Yeah, there's myotonia. I like who wrote there, myotonia. Yeah. MS, great. Yeah, dysatrophy. Yeah, myotonic dysatrophy. Perfect. That's great. That's enough. Okay. Yes. Okay, so what I'm talking about today, that you have the differential, you have to have the list of your differential for the ptosis that we will discuss today. And then after that, once you reach Horner, this is not enough. Because here there is a long story. They bought these details for a reason. They bought aortic dissection and operation and surgery and blah, blah, blah. Okay, for a reason. So you should understand that he is guiding you to reach the cause and to say it as a full diagnosis. This is a Horner syndrome. In considering the history of cardiothoracic surgery, I will consider postganglionic Horner syndrome to be the cause due to trauma or blah, blah, blah. Okay, so you need to approach the case that way. You need to present the case that way. You need to, but here in this case, I will ask you, what are you going to do to the patient? Don't tell me I will do basic investigation for now. For now, just show the examiner that you are going to do a CT test. You are going to do, you know, something will give you, let you reach the definite diagnosis. Okay? So anyway, thank you, doctor. You did it well. I will just go through this ptosis. Ptosis is common. It can come in the exam. Even Horner syndrome is 2% post cardiothoracic surgeries, and it is a cause of a lot of compensation that the patient requesting when they have this as a complication of chest cardiothoracic surgery or neck dissection. So it's a little bit an important topic in UK. Okay, so you need to be familiar with how to approach such case. So I will just have a slide now. I'm trying to be fast today. I know you are tired already, and I know it's late there now. Okay, so I will go through my page of the algorithm as fast as I can. Okay, so it's here. Okay, and then okay, this is the ptosis. Okay, we will go here through how this patient have ptosis. So we will ask, when did you discover this ptosis? Who's the one who discovered it? Okay, so you need to know, is it since long time? Is it sometime that just someone telling him that you have ptosis and this is normal eye? Okay, so you need to ask, is it unilateral or bilateral? Is it complete or incomplete? Start to hide your eyes, start to affect your vision, and you did that. You ask about that. You need to ask about when does it start, because if it is since birth, so, and this is not logic to have in the exam, but since birth we are talking about the congenital ptosis. Okay, you need to ask about the meiosis. You will not ask him if there is meiosis, but you can just, if this is a history case, and this is possible to have a history case in this such scenario. So you would ask him if he noticed any change in the shape of his pupil. Okay, sometimes he said, yes, it looks very small. It looks unequal, doctor. Okay, but anyway, you will find that in your examination of the patient. Any sweating changes, okay, or net changes, any sweating, and you ask it about that for the anhidrosis. Any shrunken eyes, it means that he will notice that one of his eyes looks smaller than usual, or looks going in, okay, more than usual. Okay, the relation to surgery, ask him any recent neck surgery, any recent chest or heart surgeries. Okay, then you will ask, you will notice that I put some of this question in different color because this is related to something, this purple color. And then there is these 4 questions in red because it's related to something else, which is it in the beginning or all of the day? Beginning of the day or all of the day? Is there a double vision or not? Is there any weakness or not? You can add here if there is headache or not. Okay, then you can ask if there's chest symptom like coughing out of blood, like continuous coughing, like loss of weight, like night sweating. So you need to ask about the cancer lung because of the pancreas tumor and because of the Lymph Adenopathy associated with chest cancer. Okay, so you need just to ask, memorize this question and ask, and then you need to memorize this page outside. While you are outside your station, you need to remember this page by heart when you have a ptosis case in history or station 5. We have a congenital causes for ptosis, we have neurogenic causes, and we have myogenic causes. For the congenital causes, which is very uncommon to find in the exam, you will expect some time. I wrote here plus or minus, okay, iris, this is typo here. There's iris heterochromia. you will find this patient has ptosis and there is a difference in the color of both eyes. Okay, this is not common, but what if they have in the hospital somebody working there and he has congenital ptosis? I think if I am an examiner, I will be interested to have a case of ptosis and to have the candidate reach a diagnosis of congenital by excluding other causes and by not seeing the iris heterochromia. For the neurogenic causes, and they need you to be familiar with this mnemonic, which is Thomas. You know, I like you to know the things by the mnemonics. This make it more easy. So for Thomas, you have this TH for the third nerve palsy. Okay, the TH for the third nerve palsy. Okay, the T. The H for the Horner syndrome. So the T for third nerve palsy, and the H for the Horner syndrome, and the OM for the ophthalmoplegic migraine, and that what good that when you ask about the headache. Okay, and the MS for the multiple sclerosis. Okay, so I think now it's easy to memorize that by the word Thomas. Okay, the T third nerve, Horner, ophthalmic migraine, and multiple sclerosis. Okay, then there is a myogenic. So the Thomas for the neurogenic, and the MLD, okay, for the MLD for the causes of the myogenic causes of ptosis. The first is myasthenia gravis, and the second is Lymph Adenopathy syndrome, and the third is dystrophia myotonic, okay, or myotonic dysatrophy. Okay, so these are three main causes that you could consider in the exam. Okay, you can include any other causes of the headache with this ophthalmoplegic migraine. I mean, if you want to, you want to memorize that for ophthalmoplegic migraine, you can add with it a cluster headache as well. And for the cluster headache, you should ask about the frequency of the headache, and you need to ask about the tearing of the eye, blocking of the nose, and these things. Okay, so remember that this is the neurogenic causes, the known. Okay, I don't mean this is the 100% causes of the ptosis, but in the exam, one of these will be your case. Okay, then the myogenic, again, it is myasthenia gravis, Lymph Adenopathy, and myotonic dysatrophy. Okay, so please, doctor, if you can close your mic. Okay, then. Okay, so here in this case, you try to first of all you need to clarify when this ptosis happened, and was that before the operation, and you ask it this question, so you exclude the congenital cause for that. Okay, for the third nerve palsy, you would expect that you will find the patient have a problem in the eye movement, and you will find the eye in abnormal direction, and there is limitation of the movement of the eye. Okay, so this is not a third nerve palsy as well. For the Horner, you found here that there is meiosis, okay, and there is ptosis, and there is a history of cardiothorax surgery. So this increased the possibility of the Horner. For absence of headache, so it is not migraine, it is not cluster headache, you need to ask about MS and show your examiner all the time that when you ask about MS, you are clearly asking about MS. So you need to ask about weakness, you need to ask about pins and needles, you need to ask about other neurological symptoms, or double vision as well, pain in movement of the eye because of the optic neuritis sometime in MS. Okay, you need to ask about any history of problem in the you have a nerve disease. Maybe you say, yes, doctor, I have multiple sclerosis. Okay, and this is a new affection for the causes the ptosis. Okay, you know the MS can hit anywhere, anytime. Okay, so you need to ask again about if these symptoms are worsening with hot bath. These questions show the examiner that you know what you are asking about, that you know that you are trying to exclude the multiple sclerosis. Okay. For the MLD, the myasthenia gravis, you will ask by this red question. You need to ask about: is it in the beginning of the day? Is it associated with double vision? Although double vision will be with many other causes. Is there a weakness? Okay. Other weaknesses. So this will answer some question about multiple sclerosis and about myasthenia. They'll say, I am tired, they have a weakness through the day. Okay, and then for the Lymph Adenopathy, you need to ask about this symptom frequency. Okay, although the Lymph Adenopathy is not affecting the eye that much. Okay, remember the myasthenia affecting the eye more than the Lymph Adenopathy, but anyway, you should consider it, and you should consider the chest. Here, the examiner wants to hear you talking about the chest, because there is a pancreas tumor, and because there is a lung tumor that is associated with Lymph Adenopathy. Both of them, okay, can cause the Horner syndrome. Okay, so here this can cause the ptosis, and the pancreas tumor can cause the Horner syndrome. So the examiner he want to hear you asking this. Then myotonic dysatrophy, you can see the face of the myotonic patient. There is myotonic face, there is the myotonic grade. He is asking your hand, he's catching your hand and he can't take it off from your hand. There is the diabetes history, there's pins and needles, there is proximal and distal weakness. So you can exclude that, okay, as the cause. So this is your approach for the differential of ptosis. Try to memorize it by heart. This will help you very much. And if you did that in the exam, the examiner will be very satisfied. And the other step, once you found that this is a Horner syndrome, you need to go to the next step, which will be why this is a Horner syndrome, what is the cause of this Horner syndrome. And again, remember, in station 5, for the doctors who didn't attend the exam before, you don't have the time to go through everything. You need to do the things very fast. So what you can memorize in the exam, go ahead and memorize it and apply it. Okay, so here you want to look for the central causes for Horner. If you don't have this history, I mean, with this history, we already have a surgery, okay, cardiothoracic surgery, so we will jump to these green boxes. Okay, otherwise, in general, if I just have a ptosis and I found there is a symptoms, there is ptosis, meiosis, and anhidrosis, so I will consider the central causes or the preganglionic causes. So I will think about here the syringomalia, which is there is a swelling that is present in the spinal cord and making the compression, and when it is compressing the C8 and T1, okay, this causes a Horner syndrome. Okay, so in this case, and you remember in my neurology lectures, we discussed the syringomalia briefly, and we said that there is dissociation, loss of sensation. You will find there is a loss of the pain and temperature, and there is preserved dorsal sensation. Okay, and you would expect as well this muscle wasting in the hand. You will see a muscle wasting in the hand as well. Okay, the jacket distribution. Then there is demyelination. Okay, for the demyelination, would expect again the demyelination hitting any preganglionic area and cause the Horner syndrome. Okay, just a second. I think you lost the share. Okay. So here the demyelination, we will ask again the question of the MS about the weakness, pins and needle, blurring of vision, weakness of vision, pain on the eye movement, double vision, and you'd expect the age of the patient as a female in middle age with the symptom of multiple sclerosis. You will ask about the neck traumas, any neck traumas that hit the areas of the first order neuron. I mean by the first order neuron that the affection between the hypothalamus and the brainstem. Okay, if the affection between the hypothalamus and the brainstem, we will consider stroke as a cause, we will consider trauma, we'll consider MS, we'll consider syringomalia, and this is more than enough. Okay, so just try to memorize these as a causes. Sometimes tumors, if you want to add to this tumor, if you have tumor compressing the first order neuron between the hypothalamus and the brainstem, that's okay as well. Okay, then we will ask about the peripheral, and this is our case today as pancreas tumor. So you need to ask about lung symptoms, and you need to ask about cancer, and you need to examine the chest, and you need to make percussion for the apical part of the chest, and you need to show that to the examiner. You know, the examiner would not expect that you get a definite diagnosis, but when he see what you are doing, you hear your approach. I will discuss what you should examine in this case, but anyway, you should show him that you are trying to see if there is a dullness on the top of the lung. So you are checking if there is a pancreas tumor. Okay, then neck surgery. Okay, you will see for any scar, you will look for any previous scar in the neck or something. Okay, or you can ask the patient. The cardiothoracic surgery, and this is our case today, cardiothoracic surgery can do it by 3 ways, can do compression by 3 ways. And the first one is direct sympathetic compression. I mean, during the operation, during the surgery, they make direct compression to the sympathetic chain, and this causes the Horner. The other thing, the chest tube, they are inserting, compressing, and cause the Horner. And the third thing is the post-op hematoma, post-operative hematoma itself. And this is important. Both of these are important because it could be temporary. And here you can answer the question of the patient. He asked you, is it temporary, doctor, or it will persist? Okay, so if it is a direct, if it is a permanent, if it is injury to the nerve, okay, it would not, it could be persistent. But if it was compression and it will relieve with time, if it is hematoma that will be drained later on, okay, so this will resolve. So you can just tell him a vague answer about it, depend on what is the cause. If it was something that compressing the nerve only, okay, so it could become improved with time, okay, but for now I can't tell you exactly if it is permanent or temporary. Both possibilities are there. Okay, then lymph adenopathy as a cause of compression as well. So you need to show the examiner that you are checking the lymph nodes of the patient. And then the central venous cath, which is very important because it's very common. The new residents that trying to learn how to do the central venous cath, okay, and this is very common, and you know that as a doctor, and they cause the injury and they cause the horror. Okay, so again, this is a possibility for that. Why this is an important issue? Because if you told the patient this is a medical error, they make a compression, they cut the nerve or whatever, any of these, you are pushing the patient to go and complain and make a request for compensation and these things. So you need to be a little bit accurate of what you are telling the patient. Always tell him there is a possibilities, there is multiple possibilities, there is many things that we need to exclude. I can't give you a definite diagnosis for now, but there is a possibility that the surgery was blah blah blah. Okay, so again, I don't want to make it hard. I noticed that from the question that I received from the doctors, that you think station 5 has too much time. You're asking about a very tiny details, and this is not the case. The examiner is not that specialized person. He just have some points that he want to see that you are hitting these points. Okay, and he will just see that you did that, you answered the concern, you did the appropriate examination, he will give you the full mark. You got it? Okay, so I will go now what important point in this case, which is very important. So just know these slides by your heart, and then go ahead and see what you should ask. Important, the doctor missed in this case, we want just to highlight it. Okay, first of all, when you are asking about this case, you need to show the examiner that you know the causes of the ptosis, and you did that for the myasthenia gravis. Okay, you need to ask if it is not the same case. If it is myasthenia and there is a possibility of myasthenia, you should remember about the treatment. He told you I'm hypertensive, you didn't ask about my past history. If I'm hypertensive, you need to know the medication I'm taking. Maybe this patient told you I have a problem in my heart rhythm and I'm taking lignocaine, I'm taking brocanamide. Does that make any concern to you with patient with ptosis? Is there any concern with patient have ptosis with the brocanamide, for example? Can you find a relation? Yeah. Drug-induced what? Yeah, exactly. Yeah, it's drug-induced myasthenia. So I want you to write now these drugs, because it is important. Myasthenia gravis is a very important topic, and they will have a special slide and case in our course about the myasthenia gravis, because recently they like it in the exam. And I think with the new change they are going to do to the PACES exam, they will like this type of cases, because you will have more time. You will have 20 minutes to discuss the case. So they will not like the very tiny cases without a lot of discussion. So they will like such cases. Anyway, I didn't create this case. You will find this case in OST book. Okay. So anyway, remember, what is the case? What is the medication that increase that? It's called myasthenia inducing medication or drug induced myasthenia. You can write it the way that I know by heart. Okay, it is macrolides and aminoglycosides and fluoroquinolones. So this is 3 antibiotics. Okay, you can add with them penicillamine. Okay, then you can add two neurological medications like lithium and phenytoin. Okay, and 2 medication for heart rhythm for lignocaine and brocanamide. So these are enough. These are the most common. Maybe there's others, but I think it's enough to know these. Okay, I'm sorry, I have flu. So anyway, thank you. Alhamdulillah. I think there is a difference between the things that worsening the myasthenia, and there is a medication that showing a drug. It's like drug-induced myasthenia. Okay, So there is some medication that make the myasthenia worse. Again, this is more details that you don't know, you don't need to discuss, but I want you to know this medication. This is the main medication that mentioned in OST and mentioned in many books. Okay, so you need to know them. This will be very helpful. Your approach in this case, again, because I see that many, and I received many questions from the candidate asking me, doctor, we are lost on the examination. I mean, once we are examining the patient, we don't know what to touch. Okay, again, I want to remind you, you should go and examine the first thing the patient have the complaint of. Okay, I mean, he has a chest operation, but his problem in his eyes, so you should go to his eyes. If his problem to breathing, if his problem is in hand, you should examine the hand first and then proceed as appropriate. Okay, so here in this patient, you need to look to the eyes. Okay, and again, I will have these slides for what to examine in each case, but this will be in our course. Okay, so you will examine the eye movement, and this is great to see if there is double vision for myasthenia and for the third nerve palsy. You will look for the iris heterochromia for the congenital ptosis. You will look for the meiosis because Horner syndrome, and you will look for the mydriasis or dilated pupil for the third nerve palsy. Okay. Okay, there. If you found a relative afferent pupillary defect, so you will tell the examiner that you want to examine the fundus, and usually he will tell you no need, okay, or it is normal or whatever, because you would expect the presence of optic atrophy, for which you need to look for multiple sclerosis as a cause. So you need to examine the fundus in any multiple sclerosis cases, okay. So once you found that there is a ptosis, meiosis, okay, and there is no ophthalmoplegia, so this case is going with the presence of surgery history. So this case going with Horner, okay, related to the operation. So you will go now and confirm that this was the cause. Okay, so you will go to check the neck for any scar, for any mass. Okay, you will look for the hand, for the wasting of syringomalia. You will check the apical lung, and you will show him that you are doing the percussion. Okay, and if you found that there is ptosis and there is no Horner and there is no third nerve palsy, so you should go and do the examination of multiple sclerosis or myasthenia gravis or myotonic dysatrophy, the 3M. Multiple sclerosis, myasthenia gravis, and myotonic dysatrophy. Okay, so here you will tell the patient that way. Okay, there is many causes, sir. Okay, maybe during the surgery there were some stretching to your blood vessels or nerves of the neck. Okay, there could be as well some collection, okay, at the site of the operation that causing this compression. We are not sure now what is the cause of that. We need to go and do some investigations in order to reach what is the exact cause, and at that time we will meet again and we can discuss this part, and we can check if this could be permanent or could be temporary. Okay, and at that time we will go back as well to the eye doctor and to the surgeon to discuss together. You are not alone in the hospital. Okay, so mention that we will discuss together and see what would be the next step that we are going to do. And if you are asking what to do in this case, I would not say basic investigation and blah blah blah. The examiner stop liking any wasting of time. If you said, I have honor to examine this gentleman who's blah blah blah, this is a time wasting and he don't like. The patients like comfortable, this is very good, but they don't like it anymore because they know that you are wasting your time, that they can ask more questions. So just go and hit the point. What are you going to do? Okay, I'm going to request chest x-ray, CT chest, okay, or CT MRI. Here you will have in the scenario that this patient change a valve. There is a valve changed in his heart. Sometimes they will write that this patient have a pacemaker. They was inserting pacemaker. Does that make any concern to you in this case? Any concern when they mention that there is a pacemaker or there is a metallic heart valve? Any
No
concern?
MRI.
Yeah, exactly. This is very good. Exactly. They put this part to check. Once you say, okay, there will be a problem on doing MRI or considering that you have a pacemaker or you have a metallic valve, we need to go back to our heart doctor in order to be sure, but because there is a risk if we did MRI for you while having these devices, okay, and blah, blah. The examiner will know that you are a safe doctor. If you just go ahead and say, okay, we're going to do MRI, the examiner will keep asking you, MRI or CT? Both MRI or CT. Okay, MRI will be more informative. Okay, thank you, doctor. Thank you. And he will see that you are not a safe doctor. Okay, because they put something in the scenario and you are the specialist who is in UK working as ST3 or more, and you still can expose the patient to this risk of MRI without even going to a specialist in the cardiology to allow you to do that. So take care. Again, every word in the scenario means something. Every word they put, it means something. So go ahead and never miss up. If they said she has a dog, this dog is for a reason. It's totally different than the USMLE. In USMLE, they are giving you things just to distract you away of the diagnosis. In MRCB, no. They give you something because this is a clue for something. Okay. So whenever you found something specific in the scenario, take care of it and consider go deeper in that. Okay. So again, you will examine, as I told you, the eye, the neck, the chest. In such case, okay, if you found Horner, you'll proceed to find the cause of Horner. If you found Thurner palsy, you will go to exclude other central causes, okay, as a stroke, as MS, demyelination, all these causes can do it. Then if it is peripheral, you will go and check what is the cause. You'll check the neck and check the chest. Okay, I know you are tired now. I hope you found that helpful. This is the case of ptosis. Again, we have still more or 5 topics in the eyes. Once you are familiar with a diabetic eye, hypertensive eye, fundus, okay, and TIA, what we said in the sudden loss and blurring of vision, and this ptosis, okay, once you're familiar with that, don't worry about the eye case, and I will make you very confident, and you will hope to find the eye case in station 5 other than being worried about having a case of fundoscopy. Okay, we will have, this will be part of our course to have some half day, at least 5 cases or 6 cases for the eye. So I'll be very confident with that. For sure, I can discuss all these in my weekly lecture. But anyway, I'm trying still, as I promised you, we will keep trying to give some free lectures in order to discuss some things, but we can discuss everything in that. If you are interested and you found we are doing well, okay, you can just contact Dr. Mahmoud and check if you are interested to join our course. My advice, if you want to join our course, because we will start registering by the next 2 days for the December 1st course. Okay, our course will be 14 days with 2 days break in between for communications and station 5 and history and neurology. Okay, if you are interested, go ahead and subscribe and let's do it. And I want you, if your exam in February, to take the course at least 1 month before, okay, in order to have time to ask, have time to practice more. Don't just take the course and go to the exam, because you still need to practice things. You still need to know your algorithm by heart. We have still more, about 55 algorithms more than we shared before. Okay, I want you to be familiar with everything. I hope that you enjoyed our lecture today. Dr. Nada and me, Dr. Mahmoud and Dr. Ahmed, we're all trying to do the best for you, whether through our free lecture or whether through our QuadriSmart course. Okay, thank you. If you have any question about the lectures of today, any question about the course, go ahead and please contact Dr. Mahmoud. Okay, you will have his number there on the promo of the course. And thank you very much for attendance. And we, as usual, I'm really, you know, nobody give reviews. I told you, give us the reviews in the group on WhatsApp. I have 5 reviews, 6 reviews, and this doesn't give me the real impact of the course. I don't need this review for advertising. I need it to know that we are doing well. You need something we want to add. You found that we are doing something helpful, okay, so you can get the benefit of whether of our free course or our QuadriSmart course. Okay, so I'm waiting for your reviews here and there. Okay, and thank you, doctor, for attendance. Thank you very much. I hope you found that helpful today. Okay, thank you. Dr. Anada, do you want to add anything? Do you want to advise the doctors anything before we go?
Well, I advise them to prepare well, and I wish them luck.
Yes. Thank you, Dr. Anada. Thank you for your effort. Thank you, doctors, for attendance, and all have a great day.
Thank everybody.
Thank you. Thank you very much. Thank you. Have a great day.